Hi everyone, it's Dr. Valerie Flores from San Diego Fertility Center. I'm very excited for today's webinar. Just going to give a little more time for people to join. I hope everyone's having a nice Thursday. I see the sun finally came out. It's always exciting. We have a few more minutes for people to join. Just bear with me as we wait for a few more people to get on board. I want to make sure people have time to join. There's a lot of stuff that we're going to be talking about today. If people are joining, I'll give it like one more minute before we get started. Okay, looks like we got a good number, so we'll go ahead and get started. Let me share my screen. Okay, great. So as I mentioned, I am Dr. Valerie Flores. I'm one of the fertility specialists here at San Diego Fertility Center. I am a reproductive endocrinologist and infertility specialist, and I'm also an assistant professor adjunct at the Yale School of Medicine. And I am the immediate past chair of the Endometriosis Special Interest Group for the American Society for Reproductive Medicine. Just to tell you a little bit about me and why endometriosis in particular is near and dear to my heart. So I'm originally from Southern California, but I completed all of my medical training on the East Coast. I went to Yale for medical school. I went to Brown University for my OBGYN residency, and then went back to Yale for my fellowship in reproductive endocrinology and infertility, and actually stayed on to work at Yale as a physician scientist. I had a grant that supported all of my research on endometriosis, some of which I'll be talking about today. My aunt actually struggled with endometriosis-related infertility, and it's actually because of her that I became interested in pursuing REI as a career, and in particular, focusing on patients with endometriosis. She told me that it was really thanks to her REI who really helped her understand what endometriosis was, how it can affect fertility, and then ultimately she was able to have her two beautiful daughters. And so hearing that story continues to inspire me to help all of my patients with infertility, including those with endometriosis as well. So with that, we'll get started. So I just want to talk a little bit about how common endometriosis is. Endometriosis affects up to 10% of reproductive aged women. In those with pelvic pain, it affects 50 to 80% of women with pelvic pain and up to 50% of women with infertility. It's classically been characterized as a pelvic disease, but what I'm hoping to show you through this presentation is that it's profoundly more than a pelvic disease. It's truly a chronic systemic disease with multifactorial effects throughout the body. And the healthcare costs in the US alone exceeds over 22 billion. It's also really important to recognize the cost that it has on women. Endo affects women at a time that's really critical to women's educational development as well as their careers. And so the true cost is the hindered potential of these women as well. What exactly is endometriosis? It's classically been defined as endometrial-like tissue outside of the uterus. So there's three layers to the uterus: the inner lining, which is the endometrium, the muscle layer, which is technically the middle layer, and then the serosal layer, which kind of acts like a little bit of a saran wrap around the uterus. The endometriosis is coming from the inner lining. So this is a picture of the uterus, this is the bladder, this is the rectum, ovary and fallopian tube. So this inner lining of the uterus, the thinking is that sometimes some of the blood that's shed during a menstrual cycle ends up going through the fallopian tubes and implanting on different areas of the pelvis. This top image here is just what it looks like under the microscope. So the endometrial tissue has glands, these the little circular areas, and then these other cells that are composed the stroma. Macroscopically, what we can see in patients who've had surgery, one of the more common lesions is what we call a powder burnt lesion of endometriosis. And then we can also see sometimes endometriosis can form a cyst on the ovaries, and that we call an endometrioma. So this is an enlarged ovary because there's a cyst of endometriosis within it. Endometriosis can be very challenging to diagnose, though. Studies have unfortunately shown that there's a 6 to 11-year delay from symptom onset to diagnosis and treatment. A lot of providers are unaware of the disease. Symptoms can be nonspecific or associated with other conditions. Pain is subjective, and sometimes social norms can inhibit the conversation. I can't tell you how many times I've had patients come to me and say that they were just told that periods were supposed to be painful, that this was just part of being a woman, but that's not true. There can be cramping associated with periods, but to have periods that are so debilitating that you can't go to school, can't go to work, you're vomiting, that's not normal. And so we're really working on, or what I'm really working on, and a lot of other endometriosis providers are working on, is really increasing awareness, educating, and so that we can empower patients. I love it when patients actually come in and tell me they think they have endometriosis because it tells me that we're doing something right in terms of increasing awareness about it. But still, there is a lot of misdiagnosis that happens as well. There was a survey of 7,000 women that showed up to 65% were misdiagnosed, and almost 50% saw more than 5 providers to ultimately get the diagnosis of endometriosis. And that's not okay, because early diagnosis and treatment can really reduce the uncertainty, the discomfort, the disease progression, and later complications. And particularly for infertility patients, it really is helpful to have an answer, and then we can tailor treatment knowing that you have endometriosis as well. But I guess the other question is, so why can it be so challenging to diagnose, or why does it take so long to diagnose, and why do people see so many providers? I think one of the biggest things to make note of is that I know I talked about how it presents as pelvic pain and can also present as infertility, but sometimes it can be asymptomatic, or other times the symptoms are a little more nonspecific. I've had patients who come in saying that they have bladder pain or rectal pain when they're having a bowel movement. And if you really start asking the question of when they get these symptoms, a lot of times it's cyclic. And so that's usually the first indication that it may be related to endometriosis. But again, why are the symptoms nonspecific, and why is endometriosis difficult to diagnose? And really, I think it goes back to the complex systemic nature of endometriosis. And so what I really want to focus on next is some of the new theories with respect to how endometriosis develops, and then how it can progress, and how the endometriosis itself can affect things like fertility as well as other organs. So I want to talk a little bit about stem cells. We tend to think of stem cells coming from the bone marrow. They can turn into really any type of cell, and they go to different organs to help for regeneration. But the uterus itself actually also has stem cells, or endometrial stem cells. So again, this is a picture here of the uterus. This is the lining of the uterus, the ovaries, and the fallopian tubes. And the most common theory I'd mentioned before was that of Sampson's theory of retrograde menstruation, which is saying that sometimes when we have a period, the blood's always supposed to come out through the vagina, but sometimes it can reflux through the fallopian tubes and implant on different areas. That's one theory for how endometriosis forms. So this little green shock view is supposed to be a uterine stem cell. And then it ends up in the pelvis and develops into endometriosis. But sometimes endometriosis can come from other sources. So for example, the bone marrow I mentioned is a very rich source of stem cells. And so the bone marrow, what we think can happen is there was a cell that was supposed to go to the uterus and help with uterine development, but it ends up getting a little confused, ends up in the pelvis again, or really on any other organ. There are some cases of endometriosis actually in the lung, and then also develops into endometriosis there. And then we can also see that as a normal part of function, sometimes the bone marrow cell does go to the right place. It goes to the uterus. But other times, what we're also finding is that the endometriosis itself releases certain factors that can have effect on other organs. So what else can it do? This is a bit of a busy slide, but really what I wanted to get across is that the endometriosis itself releases factors that can have an impact on a variety of organs: the liver, the brain, the lung, fat tissue, and can also really affect the uterus as well. So we know that endometriosis can cause a lot of inflammation. And if you think about it, it's because the endometriosis tissue is like the lining of the uterus. So every month when patients have a period, that lining grows in the uterus, and when patients are ovulating, the lining of the uterus grows. Eventually, that lining sheds if pregnancy doesn't happen. The same thing happens in the lesions, except that there's no place for that blood to go. So it causes a lot of inflammation, a lot of pain, and again, releases certain factors that can influence other organs. One of the more common ones is actually the fat tissue, or metabolism, like the liver, which is involved in the liver. It used to be a common misconception that being of a low BMI or being thin was a risk factor for endometriosis. But it's actually the reverse. It's actually that the endometriosis itself is causing changes to metabolism, and that's what tends to lead to a thinner profile. We also know that some of these factors from endo can go to the brain. There have been studies showing that there's alterations in brain ranges associated with anxiety, depression, and there's also altered pain perception. So it's not you, it really is the endo. And also the inflammation can contribute to infertility as well. And I don't tell you that to scare you and say that we cannot treat all of these things. No, we can absolutely treat it. The big thing is to recognize that this can be a manifestation of endometriosis, and then from there, guiding treatment based off of whether you're seeking pain relief or whether you're seeking fertility. So really what we see in the pelvis, what we talked about initially, is just the tip of the iceberg. The disease goes well beyond that. And so when we think about endo, while we commonly think of pain, and of course infertility is a large component, we also have to think about inflammation, we have to think about bladder dysfunction, fatigue, anxiety, depression, cardiovascular disease, and low BMI. And again, this is not to scare patients. It's really, I just want to educate you and I want to empower you, because a lot of times patients feel like it's them, that they have created some sort of problem, or that they can't handle the pain of the endometriosis or the stress associated with endometriosis, but that is not the case. The endo changes things in the body. It changes pain perception. It changes areas of the brain associated with anxiety and depression. It changes the uterus. It changes the ovaries. The important thing is that we recognize it, because we can absolutely treat every single aspect. And so that's why I bring all of these things up, so that if you feel like you have some of these symptoms, you know that you're not alone, and you can see myself or one of my colleagues here at SDFC. I did want to transition, though, a little bit. Now that we've kind of talked about endometriosis as a chronic systemic disease, I really want to now focus on how that affects fertility. And so as I mentioned before, the prevalence of endo actually increases up to 50% in women with infertility, and it can really affect various aspects of the reproductive tract. So this is supposed to represent an endometriotic lesion. It's a very busy image, but it just helps me to help you understand the various effects that it can have. So the endo, remember, causes a lot of inflammation. So that can really affect the ovaries and the eggs that are growing on the ovaries. It can also affect sperm transport through the fallopian tubes as well. So that's another way that it can impact fertility. And then we're going to go into more detail about this in a sec, but progesterone is very important for implantation. And so the endometriosis can sometimes make the lining of the uterus resistant to progesterone, and that can make it harder for an embryo to implant. So these are the various ways that endo can affect fertility. And unfortunately, we do see that in patients with endometriosis, there is a lower likelihood of getting pregnant compared to women who don't have endometriosis. And again, it's not to say that you will have infertility, but if we know that there's a history of endometriosis, we usually start talking about starting fertility treatment sooner rather than later. So how the endometriosis affects the ovaries. One way is that we can see sometimes that the egg reserve is a little bit lower in patients with endometriosis. So one of our big tests for checking ovarian reserve is anti-Mullerian hormone, which is a hormone that's made by the eggs in the ovaries. That can be lower in patients with endo, particularly those with more advanced disease. We also see a lower antral follicle count, especially in those who have cysts of endometriosis. But that being said, I do want to make it clear that the endometriosis isn't affecting the quality of the eggs. And we know that because there was a study looking at patients who had undergone IVF, who had endometriosis, who also had chromosomal testing of their embryo, so PGTA. The light blue are patients with endometriosis. The dark blue are patients without endometriosis. And what you see across all age groups is that there's no difference in the risk of abnormal chromosomes in an embryo, whether you have endometriosis or not. So it's really important, because yes, we may see a lower egg number, but the endo, thankfully, is not affecting the egg quality. Endo, as I mentioned, affects the uterus as well. So on the left-hand side, I just wanted to kind of have a visual representation of what's happening around the time of an egg developing and ultimately ovulating. So at the level of the ovaries, we see that initially in red, we have estrogen increasing as the follicle is developing. At the level of the uterine lining is thickening in response to the estrogen. Ultimately, ovulation happens, and then the dominant hormone becomes progesterone. Progesterone really stabilizes the lining of the uterus and allows it to undergo the changes that it needs to undergo for proper implantation. And just like progesterone is important for implantation, actually from the level of endometriosis, it's normally supposed to make endometriosis stop growing. So endo loves estrogen. It grows and grows and grows and causes inflammation. Normally, progesterone is supposed to counter that activity, and the endo should stop growing. However, in a large majority of patients, just like the endometriosis doesn't really respond to progesterone, it causes changes in the uterus that makes it harder for the lining of the uterus to respond to progesterone. And so that's how it can contribute to infertility at the level of the uterus. But we have treatments, and I think the treatment options will make a little more sense now that we have that background information. So endometriosis, the one other thing I wanted to mention is endometriosis can be staged. So one important thing to make note of is now we can clinically diagnose endometriosis. Now that we know a lot of these perhaps once considered non-specific symptoms, but now knowing the more systemic effects of endometriosis, it is possible to diagnose people clinically. In a lot of the studies that you may come across, though, you may read a lot about stage of endometriosis, and it ranges from stage 1 to stage 4. Stage 1 is considered very minimal disease. Stage 2 is considered mild. Stage 3 is moderate, and stage 4 is severe. But what I want to make clear is that stage does not equal pain. There have been a lot of studies looking at that. Patients can have quote unquote minimal disease and have a lot of pelvic pain or have infertility. What the staging does, it helps doctors talk to one another if we know that a patient has had surgery. And ultimately, if surgery has happened, it also sometimes helps guide fertility treatment. So technically, in anyone with endometriosis, we always still recommend starting off with fertility treatment even before you've necessarily been trying for a few months. And that's because in the general population, the likelihood of getting pregnant each month is around 20%. In endometriosis patients, it's unfortunately much lower. It's around 3%. And so that's why we say it's better to consider starting treatment sooner just to help shorten the time to pregnancy as well. And so one of the first line treatments is ovulation induction and intrauterine insemination. That's giving an oral medication to the female partner to have 2 eggs released, ideally instead of 1. And then the IUI helps bring the sperm closer to the egg and hopefully will help overcome any issues with sperm transport related to endometriosis. And then for my patients in particular, I usually will always supplement with vaginal progesterone after the IUI. And that's because, again, knowing that there can be some progesterone resistance at the level of the uterus, giving extra will hopefully help allow the uterus to be able to undergo the changes it needs to undergo for implantation. We normally recommend no more than 4 cycles for a couple of reasons. One, even in patients without endometriosis, the likelihood of conceiving with IUI, unfortunately, doesn't really increase much beyond the 4th cycle. But the other reason is, particularly for patients with endometriosis, each time you have a menstrual cycle, that can be very painful. And so we don't want to keep exposing the endometriosis to lack of pregnancy per se. And so sometimes it's better to think about moving on to in vitro fertilization, where we can provide stimulation hormones to get lots of eggs to grow. We retrieve those eggs, ultimately combine them with sperm in our embryology lab and watch them develop into embryos. And there actually are some very nice studies now looking at what are some ways that we can optimize also in vitro fertilization for patients who have endometriosis. And actually, one other thing that I wanted to mention, because I usually get this question too, is there any role for hormonal therapy prior to pursuing ovulation induction and IUI or prior to pursuing IVF? With respect to ovulation induction and IUI, we normally don't recommend it. While it may help treat pain, which is different, while it may help treat pain, a lot of the medications that exist for endo to some degree inhibit ovulation. And so studies were done to say, what if we treat the endometriosis for a few months and then try getting pregnant? It didn't really shorten the time to pregnancy. It really actually kind of prolonged the time because while patients were on medication, they couldn't really try to conceive since all of them inhibited ovulation to some degree. Surgery may be considered before ovulation induction and IUI. Surgery, though, we really reserve more for if the pain is so severe that you can't tolerate going through an IUI cycle or tolerate even trying on your own. That's when we say surgery is preferred. In terms of increasing the likelihood of success, there are some studies that say that having surgery before fertility treatment does increase the likelihood of getting pregnant with or without oral medication and IUI. But the number needed to treat is around 24 for every 1 additional pregnancy. So that's something that's very individualized. It's not a no, but it's something that when you meet with us or meet with me, we'll go over your specific case to see if surgery may be something that would be beneficial for you. With respect to IVF, surgery is actually not recommended. The thinking was that if we cleared out all the endometriosis, we would get more eggs or better quality eggs or more embryos. That actually wasn't found to be the case. If anything, there was a concern that because endo can be on the ovaries, would there be a risk of causing harm to the ovaries before doing IVF? But there is a unique situation actually where I know I mentioned that suppressing endo before, an IUI wasn't necessarily helpful, but actually suppressing endo in the setting of preparing for an embryo transfer, there actually are some new studies to say that that may increase the likelihood of success with IVF. And the reason why we're talking about this is because IVF, of course, is the best we have to offer patients, but it has been noted that sometimes even with IVF, the success rates of patients with endo is a little bit lower than patients without endo. So really, we're looking at ways to better optimize fertility treatment for endometriosis patients in particular to really help ensure that you have similar success rates. So with that, I wanted to talk to you about a study that I'm a part of actually through Yale, and actually actively enrolling patients here at San Diego Fertility Center as well. So it's using a medication called elagolix, or Orilissa is the generic name, as a medical suppression of endometriosis for 2 months prior to an embryo transfer. So the full name of the medication is a GnRH receptor antagonist, so gonadotropin-releasing hormone antagonist. What that ultimately does is it basically blocks the pituitary gland, which is normally making FSH and LH. It's blocking the ability of it to make FSH and LH. And then in doing that, it's blocking the ability of the ovaries to make estrogen. And remember, endo loves estrogen. So if we can lower the estrogen levels, we'll hopefully treat the endometriosis, remove all of that inflammation, and hopefully ultimately kind of reset the uterus to better respond to progesterone ultimately when it comes time for an embryo transfer. And a lot of the background for this really came from some original studies looking at using an injectable version, so as a GnRH receptor agonist. In the end, it does the same thing through a slightly different mechanism, but using something like Lupron, for example, for about 3 months before doing a fresh IVF cycle, meaning that after the IVF, after embryos are created, we immediately went to an embryo transfer. Now, a lot of us do mainly frozen embryo transfers, but from those studies, it was found that patients had a higher clinical pregnancy rate. So now we're using this medication that's actually already approved for treating endometriosis-associated pain. We're using it in a similar way that Lupron was used, but now before an embryo transfer. And we're looking at a few additional outcomes. So not just looking at is clinical pregnancy rate higher, but are live birth rates higher? And do we see fewer pregnancy complications that we know endometriosis patients are at risk for? So it's something really exciting, still ongoing, and definitely something that we can talk about in terms of enrollment, because I'm still enrolling patients here at SDFC as well. I did want to switch gears a little bit to talk about non-invasive testing for endometriosis, or really how can we better diagnose endometriosis in patients so that we can minimize the diagnostic delay. And so these have really, and that's because, again, surgery is technically the gold standard. I say technically because I really think we should be focusing more on being able to diagnose it clinically, but surgery has been considered the gold standard in that you can visually see the endometriosis, you can take a biopsy, have a pathologist review it as well, and see if endometriosis is present or not. But surgery is invasive, and so really, in addition to diagnosing clinically, people have looked a lot at, are there other things that we can utilize that doesn't involve surgery that allows for a more rapid diagnosis? So that's been focused on imaging, on blood markers, and also uterine markers. For imaging, the two main tools that we have are vaginal ultrasound and pelvic MRI. A vaginal ultrasound can definitely see a cyst of endometriosis. It's a little bit harder to see in that one of those first slides that I showed you, that little powder burnt lesion. That usually can't get picked up by an ultrasound. It may get picked up by an MRI. So none of these tests are perfect for diagnosing endo. And the one thing that I really want to emphasize is that even if the exam is quote unquote normal, that does not mean that you do not have endo. Really, I would say where imaging plays a role is in making sure that we're not missing another reason for why pelvic pain is present, for example, or why fertility or pregnancy hasn't happened. So even if you've been told your ultrasound is normal or your MRI doesn't show endo, that does not equal no endo. That's where really a lot of the symptoms come into play for helping to diagnose that. People have also looked at blood markers, so serum markers, so looking at inflammatory markers. There have been a lot of studies looking at different, we call them cytokines, that are involved in the inflammatory pathway. There's a cancer marker called CA-125 that's been used more for ovarian cancer diagnosis. And then there's this molecule that's involved in blood vessel development, particularly for endometriosis, called VEGF. Unfortunately, also not recommended, not even in combination. They haven't been reliably able to predict endo. They're a little too nonspecific. There is one type of blood marker, however, that's still actively being investigated, and at least in preliminary studies has been shown to accurately diagnose endometriosis. And this is some work actually that I was involved in when I was at Yale. We were measuring microRNAs. So there's a bit of a busy slide, but I'm going to break it down a little bit. So on the left side, I'm really just showing these microRNAs. They're these little small molecules that can bind to other pieces of RNA that are normally involved in transcribing genes. We see that on the right-hand side, these are several that are upregulated in endo. And then on the left-hand side, these are two that are downregulated in endo. Ultimately, a combination of 6 microRNAs was basically put into a program, and then in patients who were actually also undergoing surgery for endometriosis. And what this is showing is that there was essentially a 93% accuracy in diagnosing endometriosis with these 6 microRNAs. So the reason why I say it's still undergoing investigation is because in the original study, 100 subjects were included. And so we want to increase the sample size to really help ensure that it's truly accurate. But this is really exciting because it really would be one blood test that would be able to diagnose endometriosis. So more to come on that. The other uterine marker that we have also looked at is actually something called receptivo. So that's an endometrial biopsy. And what that's looking for is something called BCL6. It's a marker of cellular proliferation and also in some ways inflammation. It has been found to be increased in the uterus in patients with endometriosis. And so this I'm just showing, it was basically histologically, it was looked at under a microscope after staining for this particular marker was done. And here you're seeing control patients without endometriosis, without infertility. And then you're also seeing patients who underwent laparoscopy who did not have endo, and then patients who underwent laparoscopy who did have endo. And what you're seeing is a much higher expression of the BCL6 in patients with endometriosis. This is a good test. It's not a perfect test because, again, what it's really looking at is inflammation, which can be due to endo and can be due to other conditions. So it's definitely something we offer here at STFCN that I've done before. But I think, again, it's also important to focus on being able to diagnose clinically as well. And so if clinically you have endo, we don't necessarily need to do the biopsy, but of course, it's definitely something that we offer and can talk about more. The next thing I wanted to talk about is actually some research that I've also worked on in the lab. So really looking at progesterone receptor as a marker for predicting response to medical therapy and endometriosis. So I know we've talked a lot about how endometriosis affects fertility, but endometriosis also can cause pain. And in those who are not seeking fertility, usually medical therapy is first line. In particular, progesterone-based therapies are first line. However, up to 1/3 of women don't respond to progestin-based therapy. They are progesterone resistant. And so the question is, one, what do we do if that happens? And two, is there a better way at predicting this? And so how progesterone exerts its actions at the level of the uterus is through its receptor, which is called the progesterone receptor, or PR for short. So what I wanted to look at was whether or not we could predict who would or would not respond to progestin-based therapy based off of what their progesterone receptor status was. So this was in women who were undergoing surgery for endometriosis, and they had lesions of endometriosis that were collected. They were placed onto a slide, and then I ultimately stained or did some immunohistochemical staining to really identify the progesterone receptor, which is in brown. This is the clearest image, so I'll focus on this one first, but this is really looking at the stromal cells here, and then these little circular areas, well, irregularly shaped circles and ovals. These are the glands, and this is like the surface glands of the lesion. Remember, it looks like the uterine tissue because it's uterine-like tissue. And what I was trying to determine is a lot of these patients who had surgery, most of them had actually failed progestin-based therapy, which is why they were having surgery. A few of them had actually done very well and actually were only coming off of their progesterone or their birth control pills because they wanted to get pregnant. And so what I found is in patients who had high levels of the progesterone receptor, there was a 100% response to progestin-based therapy. So these were the women who had come off of their birth control pills because they wanted to conceive and then started having pain. Then there was another group here where in patients who did not respond to progestin-based therapy, who had low PR, there was only a 6% response to progestin-based therapy. And then there was this medium group here where only 21% responded to progestin-based therapy. So they had some progesterone receptor, not a lot, but enough that we would have thought they would have also responded, but it was actually only a 21% response rate. So this is nice because, again, it does require surgery, but it's really more reserved for patients who are undergoing surgery already. Sometimes these patients get put right back on the same medical therapy that was not working for them. And so if we can test for the progesterone receptor and know that it's low, for example, then we have other options. We have medications like the Orilissa, which is really lowering progesterone levels specifically. I'm sorry, lowering estrogen levels specifically. And so may be better for these patients who aren't responding to progesterone because they don't have progesterone receptor. This is something a little bit newer that I've been working on. So it kind of relates to this group here that had progesterone receptor, but wasn't actually responding to progestin-based therapy. I started looking at, I really like the name, this protein called SUMO. It stands for small ubiquitin-like modifier proteins. So SUMO will bind to something like the progesterone receptor and just render it non-functional. So I thought it might explain why in some people who had progesterone receptor but weren't responding to progestin-based therapy, maybe their progesterone receptor was sumolated. And I found that that actually was the case. So it's a little bit of a busy slide, but essentially I did something called a Western blot where I was able to detect the two isoforms of the progesterone receptor, PRB and PRA. And then I stained with different colored antibodies. I was also looking at SUMO. And so green is the progesterone receptor. So here's PRB, here's PRA. Red is SUMO. When you combine green and red, you get yellow. And so what I was finding is that PRA was sumolated. And that's really actually relevant because it's that progesterone receptor in particular is really important for carrying out the normal functions of progesterone, which is allowing the uterus to undergo the changes that it needs to undergo for implantation. And these figures here are just showing that in endometriosis, there was more sumolation of PRA. And it's not shown here because I'm still working on the data, but we are seeing more sumolation as well in patients with infertility. So this will hopefully be impactful because it'll be interesting to see that as we treat patients, for example, before IVF with the medication Orilissa, which is knocking out the inflammation, hopefully helping to reset the uterus to respond to progesterone, to see if we see an improvement in the uterine lining as well, in terms of the uterine lining not being stimulated. So I know that was a lot, but I did want to kind of circle back into clinical care and how we manage patients. So the biggest thing is when patients present with endometriosis, first is the diagnosis. And so I'm always happy to see patients who think that they might have endo or who know they have endo to really go through this again, because I think it really is validating. Again, it's so hard. I've had patients come in who really just have not felt heard, who have felt that they've had endo their whole lives and it's been dismissed. And so I definitely want to see you just to really help validate everything, explain the symptoms that you have, and then really tailor therapy for you. In patients who have pain, usually we're recommending, again, progesterone-based therapy to start. However, knowing that there is progesterone resistance, switching over to medications that more specifically target estrogen production. Of course, surgery also plays a role, again, if medications aren't helping or some patients really want more immediate relief. I totally understand that. It's just important to recognize that endo can come back. And so making sure we still find a medication that works for you even after surgery. In patients who are presenting with infertility, again, considering starting immediately with oral medications and IUI, but not going beyond 3 to 4 cycles, or deciding that, particularly in those with more severe forms of endo, going straight to in vitro fertilization, but in particular also focusing on using medications to treat the endo for 2 months before planning an embryo transfer. And then also, I just wanted to touch upon egg freezing as well. I think egg freezing is particularly important for patients with endometriosis because, one, as we talked about, the egg reserve can be lower in patients with endometriosis. Also, if patients have undergone a lot of surgeries or if there's a concern that multiple surgeries may happen, we really want to preserve the ovaries or preserve the eggs. And so egg freezing really represents a great way to do that. Also, it's taking the eggs out of that inflammatory environment as well. So it's a really good option for any woman, but in particular, I think it's a really great option for patients with endometriosis. And so with that, I just wanted to summarize. Endometriosis-related infertility is common. In fact, actually, one of the more common tests that we did for patients who are undergoing an infertility evaluation was a laparoscopy. Not that I'm saying we need to go back to that. I really think that we can diagnose it clinically now. But it is very, very common. It was diagnosed up to 40% of the time in cases of infertility when laparoscopy was the routine. And so it's really important to recognize that it's much more common than individuals realize. I know we look a lot at SART data to look at success rates, and I know initially they do seem similar, at least between endometriosis and unexplained infertility. But if you look at endo and all other diagnoses of infertility, you do see that the endo success rates are a little bit lower. And so that's where things like treating the endo before an embryo transfer can really help maximize success for patients with endo. Again, the symptoms can be varied. They're not always the same for one endo patient to the other. And so really focusing on understanding the systemic effects of endo and really, of course, emphasizing the need for a clinical diagnosis. We do need to focus on the systemic manifestations, not just from the perspective of fertility treatment and pain management, but also from the perspective of quality of life. There have been a lot of studies looking at both surgery and medical therapy, drastically improving quality of life for patients. And so that's our goal, to really help make sure that we help you along your journey, whether that's pain management or fertility. And then again, these small molecules, these microRNAs, potentially being available soon for non-invasive diagnosis of endometriosis, hopefully avoiding more diagnostic delays. And those who are seeking pain management, using progesterone receptor as a biomarker for predicting response, and then also using something like SUMO maybe as a biomarker to see who in particular would benefit from IVF or who may benefit from the Oralisa medication before planning an embryo transfer. Precision medicine is important. It's something that I talk about a lot, both from the perspective of treating pain and optimizing the medical therapy for your particular type of endo, but also equally importantly, modifying your treatment protocols when it comes to fertility treatment, knowing that you have endometriosis. We really focus on individualized care. And then again, ongoing research looking at ways that we can optimize success rates with IVF and fertility treatment as a whole. And I think that Oralisa medication really represents a novel way to do that. With that, I'd just like to say thank you all for taking time out of your busy schedules. And I just wanted to acknowledge the grant support, the research support that I've had to do some of the research that I talked about here with you. I'll stop sharing the screen. I'm happy to take any questions. And I think you can put them in the chat. One of the questions was asking about treatment for pain management, if there's anything other than birth control pills, for example, or the Oralisa medication, and there are. So birth control pills, although they have estrogen in them, the dominant component really is progesterone. When that is no longer working, then we focus more on lowering estrogen levels. We can do that with things like Lupron, which is a GnRH receptor agonist. We can do that with things like Oralisa. an antagonist, but in the end, they both do the same thing. They lower estrogen levels. The difference is that the Oralist is an oral medication, whereas Lupron is an intramuscular injection. We can also use letrozole, which you may have heard about for ovulation induction, but really we can also use it for lowering estrogen levels. We can do progesterone only, and then there are also some testosterone derivatives that really help treat endo, the main one being danazol. One of the other questions is, are there any other modifications that we can make to an IVF protocol for patients with endo? Um, Actually, there have been studies looking at that too, looking at the more common protocol is where we give FSH and LH and then add on something like a GnRH receptor antagonist to avoid any of the eggs that are developing from ovulating. There are also other protocols where we actually use Lupron to really downregulate, really more the ovaries, not so much from the perspective of the endo, but just the ovaries to prevent any follicles from growing before we can stimulate you. The thinking in the past was that Lupron was better for patients with endo. But so far, we haven't seen any difference in that initial protocol. The biggest difference is really coming from in preparing for an embryo transfer, suppressing the endometriosis before an embryo transfer. Okay. Those two questions got repeated, but I think that was everything. I just want to say thank you to everyone again. I'm definitely looking forward to hopefully seeing some of you in a consult, and happy Endometriosis Awareness Month.